I'm on my little shoulder mic thing. First and foremost, good morning.
Good morning.
And a heartfelt thank you to each and every one of you. I know what you're doing, and I know why you're doing it, and I am always impressed with this organization in terms of the leadership on a national level that you guys are putting out in the world. You are saving lives. It's that simple. And I just need to acknowledge that, and I just need you to know that you are seen. And this movement is picking up speed every year. We are on our way to liberation, and I want to thank you. And I've got to figure out how to do my slides now. Hold on. Okay. So thank you, Kendra, for that very, very generous introduction. And thank you for calling our ancestor, our dear sister Claudia Booker, into the room today with us. Those of you who know Claudia, I don't have to say another word. And those of you who were touched by her work, I also know you know what that means. So let me start with, and in case you didn't notice, I'm not from here. I've been in this country, though, 32 years. I got here in 34, I can't do math, 1989, I got here. And I started an organization called Common Sense Childbirth because I could not see a single scrap of common sense around maternal child health. I was like, what on earth is going on? I was a midwife when I got here. I got off a plane in Orlando with Disney stars in my eyes, and I was like, let me go ahead and get my work started. I'm going to be a midwife. Let me go to the hospitals and get a job. That didn't work out. But what has been happening historically, and obviously since I arrived, this is the first message I got. Black babies are dying? What is that? But mothers are dying too. And it's only recently, because like you said, 30-some years I've been here, we just started talking about mothers. 10 years? Is it 10? Have we got to 15 years yet? I don't think it's even 15 years. Up until 10 years ago, it was like, infant mortality, babies are dying, oh my gosh, we don't know, throw our hands up, and yet the mothers were ignored. Now we're counting Black and indigenous and all races of mothers and ethnicities of mothers that are dying in the United States. And I want you, as we talk today, as you formulate any questions, anything that comes up for you, to think through what that means. We just now got some recognition that the baby is coming through a person. Hello? Weird stuff, right? This is back in 2010 when Amnesty International sounded the alarm. They were the first to say something out loud. They had a report called Deadly Delivery. And we were here at Congress talking to legislators about the fact that maternal health was a human rights issue. So yeah, I'm a midwife. This is me trying to be cute back in 1981 when I graduated, and I was trained in London. See that little hat and all that cool midwife stuff was going on. And then I made it to Orlando and Winter Garden, Florida, where I still practice to this day. So let's just get to the point, because we all know what's going on. We know how we want our loved ones to be treated every single time without fail. If we love somebody, if we care about somebody, that's how we want it to be. And this is how we need it to be to resolve this so-called crisis, which is not a crisis, it's a continuum. We need that everybody gets treated the same. So let me share a little bit of a story here. This woman you see here, this is her in a hospital, obviously, you can tell. And what happened here was, this is a transfer from my birth center. I have a birthing center in Winter Garden, a freestanding center where we do community birth. And we deliver the healthy and the straightforward and the, folk who have a clue, who choose midwives and birth center. So this woman actually was having her third baby with us, and she got in a little trouble at the birth center in that she was pushing for 2 hours and nothing happening. So we said, let's go in. And so you see me here, I got to be alongside of her. When I go to the hospital, I'm a direct entry midwife, I'm not a nurse. So when I go in, I don't get to have the privilege of continuing care and making management decisions. But I've worked really hard in Orlando to be very supportive of this transfer situation so that everybody wins. And so just as usual, I bounce into the hospital with my patient and everybody's happy. Look at that nurse's face, right? She's good. we're all having a time, and so Mama's got the oxygen on because that's what you do at the hospital for some reason, right? And the straps are on the belly. But remember, her problem was she couldn't move this big old baby out of her bottom. So, whoop, look what happened. She had the baby. And underneath that towel is a 10-pound child, right? But here's what I want you to know about this particular scenario. The transfer went smoothly. The nurse was smiling. Doc came in, sat down, and asked Mom what her birth plan was. Oh, I know you were with Jenny, so you must have wanted to have a natural birth. What's your birth plan? That question was asked. Well, let's see then. Let's see how you do. She turned out to be able to push the baby out. Everybody was supportive of that birth plan. Everybody was on board with that birth plan. Big old fat macrosomic baby came out of her. And look at those faces, right? The relief, everyone, including me. I'm happy to. So I want to come back to that story in a minute, but before I go there, let's talk about maternotoxic zones, because that's what we're up against. That's what we are doing, whether we're doing it in the community, whether we're doing it in the institution, whether we're doing it in our workplace, wherever we are, maternotoxicity shows up. That's what's killing mothers, killing babies, causing harm. And so I made that word up because I couldn't see anything else that kind of described what I'm talking about. And so what it means is basically, you wouldn't want to be in that area, that zone, that neighborhood, that hospital room, yourself or your loved one. You wouldn't want them anywhere near maternotoxicity because it's lethal, right? So you wouldn't want to do that. But what we do, unfortunately, is a lot of times, oh, the social determinants of health, that's what she's talking about. No, that's not what I'm talking about. Of course, social determinants of health have some impact on outcomes, right? But let's not get too lazy around how we use that terminology. Do you know how much money is changing hands over maternotoxicity and using the social determinants as the reason? Maternotoxicity can show up anywhere. I call it pop-up maternotoxicity. So if you know Serena Williams' story, you can understand what I'm talking about. Because guess what? In the midst of a big old fancy hospital with all kinds of money, celebrity power, insurance, it popped right up, didn't it? Because Serena nearly died. That's how we know it was there. We don't know who was the perpetrator, we don't know what was the environment, but we know she nearly died. Therefore, maternotoxicity was in play. So let me tell you about this young lady. So along with my birth center, I have what we call easy access clinics. And easy access clinics are prenatal care clinics, postpartum care clinics, women's health care clinics, where they're in the neighborhoods that need them. They are barrier-free. There isn't any reason why you can't have access and be seen and supported at an easy access clinic. No one turned away. That's our motto. Every person, every time. So we provide prenatal care with the midwifery model because we're midwives, nurse practitioners also. So in the easy access clinic, people come to us for their outpatient care because they want a hospital birth. They feel safer in a hospital, or they prefer a hospital, or they don't know anything else and they don't want to hear about anything else. They're good with what they've made their decision, and that's their prerogative, it's their choice. So every woman and person that's coming through easy access is hospital bound for that labor and delivery day. So let me tell you about this young lady. She came into our clinic for her 38-week appointment and just sitting in the waiting room with our doulas and our supporters hanging out, and someone came running in the back and said, "Jenny, can you hurry up and see her? She doesn't look right. She keeps pulling these faces." And I'm like, "Okay, quick, bring her back." We got her on the table, 8 centimeters. 8. Back bulging. I'm like, oh, oops. Now, this is an easy access clinic, not the birth center. Not like we've got beds down the hall that we can run and deliver the baby. Did she want the birth center birth? No, because she wasn't in the birth center. Right? If we just listen to people, we'll all be okay. So we said, okay, we best get this mama over to the hospital real quick. Call the ambulance. So by the time the ambulance got there, she's looking even more like, So I'm like, let me get in this ambulance with her, because we're not going to make it. Sure enough, we went round the corner on 2 wheels, boom, baby's out. And look at this baby. Okay, so the first picture is mama looking like, what happened? I just came for an appointment. Like, I don't have any stuff. My bag is not packed, oh my gosh, right? All of that, that's what that face is. Look at the baby though. This is immediately after it's out, right? So I'm in the back of the truck, remember, because what do EMTs do? They do EMT stuff, right? Like they get the scalpel out of the OB kit and they get all the, you know, they don't know. So I have this baby skin to skin and the baby's happy. The second picture, by this time we're at the triage department. Now, keep in mind, she was already planning a hospital birth. Keep in mind, we were transferring to a maternity hospital. Keep in mind that the triage department at the maternity hospital receives people in labor all day long. So ask yourselves, why was there a mad panic and everyone running around like chickens? Because the baby was born in an ambulance. Like what? So there were chickens. She's looking peaceful, thank goodness. I'm trying to hold on with doing the bubble of peace routine, doula Jenny, right? And look at this woman. Baby skin to skin, looking for the nipple. Everybody's happy. What was the fight about in the hallway? Anybody want to suggest what was going on with the nurses, the doctors, the residents, the attendings? What was the argument that was in the hallway? Anybody want to guess? Billy, who's going to catch the placenta? Big drama. Big drama. This woman is fine. This baby is fine. You would think then that everyone, oh, okay, great, let's just deliver this placenta and move her upstairs to labor. No, they fought their fight. The residents won. They got the placenta. Okay, whatever. So I'm thinking my job here is done. I'm going back to my clinic. But I should never have left her side. By the time she got upstairs to labor room, a nurse decided the baby needed a bottle. Maternal toxicity. Inside of the institution that is claiming and trying to right these egregious wrongs and harms and end this atrocious maternal mortality, morbidity crisis. This mother survived the birth. There wasn't any reason why she couldn't establish that breastfeeding relationship, except the nurse wrestled the baby out of her arms. She was denied her golden hour. We already had half of the flipping golden hour in the ambulance. These are the little small ways that things change, because you remember, look at this child. Is there any reason to interfere with this bonding? Think about the impact of not breastfeeding, because she was never successful with this one. The other baby she had, she breastfed. This one she didn't. The impact and the protective value of breastfeeding. And if you were to look at the stats, what would it say? Normal delivery, healthy, everybody. Do you see how we must not take our eyes off the ball here? We must not let these ways of being, this extraction of community to get more studies done, more resources put into making more money around. We have to break those cycles. We have to fight from the perspective of standing with our communities. And we have to lead from that place, because left alone, this will continue. Why would this ever change? This is work from a couple of years ago, the Birthplace Lab out of Canada, where they did what we already know. Once again, more studies to say the same thing. This is what's going on. This is the first qualitative work around experience. We've got more work coming, but this tells us everything we need to know. And I want us, even though this is hospital-based, asking about hospital experiences, it could be in any doctor's office. It could be in any health department. It could be in any clinic. And it's not because people are wicked and mean. It's because the system says it's okay to behave like this. Do you think Serena's nurse got written up and fired? No. Where's the outrage? How much evidence do we need? And why are we not, and of course we are, but you know, why is it not a general consensus to be outraged on a daily basis, such that some of this can be finished right now? Because the cure is not really expensive, it's not difficult, Look what you guys have achieved right here in Virginia. The gargantuan efforts that you've put in, but if we had support, if we had funding, if we had recognition, if we had collaboration, how hard would it be? It's not going to take a lot. If you want things to read, because you've got nothing else to do, there's a great article, Dr. Monica McLemore, and I really appreciate these sentiments. If you want to prevent women from dying, stop blaming them. It's pretty simple. You already know that it works, right? Every time you provide respectful care with dignity, non-judgmental, what happens? The cervix locks tight. Like, for real. The supposed cervix that's going to burst open at 28 weeks suddenly will go to 38 or 40. Where's the physiology in that? Like, huh? Think about that. Is it that simple? Seems to be. So maternal toxicity, let's go again. Can be lethal. Yes, we agree?
Yes.
It's leading to increase in the morbidity and mortality because this is why our statistics are worsening, because maternal toxicity is worsening. So this sort of backwards move with us doing our best efforts, and us I mean like the entire country, like we've got all these supports supposedly. We've got maternal mortality review boards now. We used to just have infant mortality, now we have maternal. That's awesome, right? No, not really. Because what's happening after you finish reviewing? Oh, well, she was bad and wrong. She didn't do X, she didn't do Y. She's ugly. Right? At the end of the day, it doesn't matter what you write at the end of your review, she's still dead. So we have the fact that the toxicity shows up in any and everywhere, much of it unrecognized. Let's go back to maternal mortality review boards, for example. How many community members are on those boards? Very few, if any. How many doulas are on those boards? Very few. How many midwives even? Right? Like an entire country full of maternal mortality review boards without people who actually know something about the maternal mortality crisis? Because it's not a physiological problem, is it? If the doctors are sitting talking about it, they might want to think about, well, maybe we should have done the C-section this way or that way. Okay, great. Meantime, where's the problem? Where's the genesis of the problem? In the community, in the institution, in the academy. I said it out loud. Okay. So, there's the other piece though. The impact on us as providers, as supporters, as community members, as families. The impact of maternal toxicity is on us as well because we are struggling with this continued moral injury and frustration, and I'm going to say trauma, because we can see in plain sight. And what can we do about it? There's a helplessness that shows up, and that's hard. So I think we're doing trauma-informed care for our clients. I want to ask us to keep considering, how do we do trauma-informed care, love and support for ourselves and each other? We have to figure a way to keep lifting each other up. When we just heard the anthem sung so beautifully, everyone is moved. We're all wiping tears for different reasons, but we all have the same visceral response. This work is justice work. This work is movement building. We have to take both sides, both and, to get where we're trying to go. So I have this model. I call it the JJ way. I couldn't think of anything better, and it's too late now. And so our mission is simply to inspire some change in this system. As we re-empower the family, we need to support and re-empower the providers. And I'm talking about across the spectrum. I feel for those MFMs and perinatologists. They're in a real pickle. going to say that the same thing they've been doing is working and keep doing it. In the absence of the other pieces that we know need to be part of high-risk care. You have a gestational diabetic and it's like, here's the diet and here's the insulin, and go on, have a nice day. When an additional piece of support, encouragement, recognition of the truth of where this person is and what they actually need at the same time as their insulin shot is ignored. I had 2 diabetic mothers that came to my clinic this week for postpartum care with beautiful babies. Both of those mothers couldn't find care in our area. One of them came to me at 34 weeks pregnant, having been looking since she was 15 weeks. Do you know, it may be the same in Virginia, I'm sure it is across the stinking country. You can't get into MFM on your own. You can't rock up to the front desk at the perinatology office. Oh, I've got gestational diabetes. Can I get an appointment, please? Are you kidding? Go get a doctor. Oh my gosh. If we don't have the records. Really? Like, you've got time to pretend to be diabetic? So you can get in? The barriers are structural. The harms are structural. The people that are employed in the systems are stuck. The front desk lady is being told, don't have her, give her an appointment until she brings her full prenatal panel and her ultrasound. If she can't find a physician, how's she going to get that? If she goes to the triage, what do they say at the ER? Oh, well, you need to go find a doctor tomorrow morning. Here's the phone number. Huh? Do you see where these barriers are and how the onus is on us to figure it out, break it down, navigate, advocate, fight on behalf of these families? Why are we hoping they're going to fix it themselves? How could they? So, yeah, every person wants a healthy baby, every person deserves one. This is a world thing. Everybody else figured out. Maternity care is a priority. Mothers, babies, families are a priority. The World Health Organization, Safe Motherhood, you know about White Ribbon, you know about all these wonderful programs internationally. You know about when there's high mortality, and there are many countries with higher mortality than ours. What's the first thing we do? Well, we send all the Americans over to fix it. Here we come with our free care. We got the way, we're sending all the consultants, money's changing hands. Is it possible then that all we need to do is create a culture and an environment that supports all pregnant people? Is that it? Is it that simple? I'm here to say it is. I think you guys figured it out too. You wouldn't be making such great strides if you hadn't, right? And I want to again encourage you, please keep going, keep fighting. But what we did, and thank you so much, Kenda and Birth in Color RVA, for being a perinatal safe spot. We have worked out that if we kind of find each other and share with each other and mentor and support each other and do what we call collective care, do what we call collective leadership, collective organizing, we will prevail. On a national level, that's what we're up to. And so anybody can be a safe spot, individual. You could do it remote, you could do it from your living room, it doesn't really matter, you're already doing it. Anybody, any organization, any group, any collective, any team, any church, anybody who understands what maternal toxicity is and wants to do something about it. End of story. That is how you belong. That's it. It's that simple. We are excited because at this point we're up to 190 perinatal safe spots on our map. And across the nation, I'm excited about that. So let's go back. Time-wise, am I okay time? Okay. All right. This is what we're talking about. Safety, first and foremost. Quality and workforce development. You're in the workforce. I know you know this, but I'm just going to reiterate it. This is the workforce that will change this problem. This will be where the transformation happens. You're already here. Let's be intentional. We are fighting for the safety and the quality of maternal health care in this country. There isn't any other country in the world that has this distinct fight. And why? Because there isn't any other country in the world that has this level of racism, classism, discrimination baked into its structure. That's why. The J.J. Ray model, we have 4 tenets: access, connection, knowledge, and empowerment. We need that not only for mother-baby, for family, for community, we need that for ourselves. We need access to each other. I need to come and see your faces and get hugs and hold your hand and feel you, to know we are all on the same page, to know we're fighting together. We need access to each other. We need access to the support that we can give each other, so our connections remain strong, so this movement will prevail. We need to share the knowledge, the truth. The truth. Let's not pretend, let's not join in. And we will be empowered. Just some of the stats so you know that I'm not just up here talking for the sake of talking. Since 2006 we started collecting our data. So it's collected from the Easy Access Clinic patients. These are the women, people who are going to the hospital on purpose, not the midwifery cohort. We all know midwifery is wonderful, yeah, that's great. Kumbaya. What we don't know is the impact of a midwifery model on people who don't want midwives. That's what this data is. The midwifery model could be with a physician, could be with a nurse practitioner, could be with a family practice doc, could be with the acupuncturist. Doesn't matter. Midwifery model of care is to center the mother, baby, center the family. Have some respect. Zip it up. That's the midwifery model of care. So look what we got. We enrolled 100 into the cohort. We enrolled prospectively, so before they were delivered, and we've got the outcomes after. Out of 100 women, Easy Access Clinic patients with all kinds of different social problems, not one Black or Hispanic woman had a low birth rate or premature baby. Not one. The majority of the people in the study were of color. The premature baby showed up in our white population, and interestingly, each of those people in that group were smokers. 2006, back in the day, right? We've come a long way. We don't have many smokers now. So by 2007, we had eliminated the disparity in our area. 95% of the babies in that study were 7.5 pounds. 95% of the women delivered after 39 weeks. What did we do? Let's just go back. What was the secret sauce? Oh, being decent? Saying no one turned away? Listening? I'm not talking about McKenna. I'm not talking about putting a cerclage in your cervix. I'm not talking about we need you in the high-risk unit on your back for 6 weeks. None of that nonsense was part of this study. These are the folk who were not, those counterparts who were not in our program that year. Let me go back. Look at the Black rate for Orange County. 21% the same year we did this study. Do you hear me? 1 in 5 Black women having a premature baby. Latinas, 15%. What? Why? Okay, let me calm down here. So, 2014, this was the one that we actually managed to get a higher breastfeeding rate for Black women than white women in the county and in the state. Interesting, huh? Access. No one turned away. No judgment, no drama. You can come in at 36 weeks pregnant and have never seen a doctor, and we don't care. Because there's a baby in your belly and it's going to come out. So it doesn't matter to us. Connections. Once people feel safe and they build trust, they will come, they will disclose, they will comply, they will do all the things, because that's all anybody's looking for. Knowledge. We share knowledge, but we're really more interested in learning about that individual, that situation, that family. We need knowledge from them versus us imparting our knowledge. Like, what do we actually know? Until we know them, we don't know anything. And empowerment. That was one of the waiting room doulas. So safety, okay? We've got to look at investing in solutions to maintain the safety. We don't want to do one thing for a year because the grant ran out and now we're sorry and go away. We don't want to do that. We need to invest and maintain the solutions because they're working and they are safer. Same with the quality. Hospital systems can support, but support what we say, support what we do, and support why we do it this way. They don't have to necessarily do what we're doing, they just need to support what we're doing. There's a difference. They need to help us from a strategic place. They want to see those outcomes, they need to understand how and where to get them from. We need those protocols. Remember at the beginning I showed you, here I come with my patient from the birth center and everybody's smiling. That wasn't like that always. I had to fight for that. It took me years of building and schmoozing and bringing donuts and falling over everybody. Now we're okay. I did that because the patients deserve that. Look at the young lady, we went into the hospital in the ambulance. They almost got it done until the last minute. You just can't take your eye off the game because it can be that quick. So we have to look at how do we get our collaborative protocols where everyone agrees that they're going to hold them. They're not just written on paper. Same with the policies. Stop writing policies and then nothing. That's not working either. These are some of our, well, I'll go left to right. June's on the left, she's a community doula. Megan is now a nurse practitioner. She started as a birth assistant. Katrina with the pink stethoscope is still with me 20 years in. We work as a team, and then Alexis, who's not with me any longer, she's a medical assistant as well, and she was almost 10 years before she moved on. She's doing her RN right now. We must grow our pipeline. You guys who are out there on the ground, if you have an interest, a heart for this work, please keep moving up that pipeline. Please, let's support you to get there. We want midwives, we want nurse practitioners, we need physicians, we need MFM. We need you. So those are some of the solutions, but they are community-based, community-owned, community-led. The providers and practitioners, we need to know and support each other's disciplines, each other's passions, and so that way we are building out trusted providers. Remember the grand midwives, the so-called granny midwives? Do you think they had a network? Imagine, they didn't even have a phone. They didn't have social media. But somehow they got it done. They delivered America. They delivered everybody. They delivered black, they delivered white. From enslavement, they delivered everybody. The commodity of bodies that built America was because the midwives delivered the babies. That's how we're here. Community. It's protective in all materno-toxic situations. Where there is representation from community, of community, with community, materno-toxicity disappears. It's gone. We need to stay in our team mentality. Let's stop doing the lone wolf. Let's stop doing the prima donna. We need to hold together. And we need to bring the youngsters up. Keep working on training folk and supporting folk. Let's keep working on building the interdisciplinary and the collaborative practices so that we can get this. Look at these mamas. This is our postpartum group at the clinic. And I want to point out the thighs. If you would please look at the thighs and see the rolls. These are the breastfed chunkies. So what do we need? We need access ourselves to safe quality maternity care for all women. We need the appropriate level of providers who have that humility, cultural humility, willingness to acknowledge and agree about the truth. We need access to all levels of care. And as providers, we need understanding of these inbuilt historical and structural harms that continue to thwart our every turn. We need everyone to understand that the cultural humility needs to reach in. It's not just implicit bias. It's a start, but it's not enough because the structure remains with implicit bias. The implicit bias training is individualized, and right now we need the structural change. We need the institutional change. And we need our students. And we need them on scholarships, like big time. We need stipends, we need support, so they can finish and get out and hang their shingle. If you want to read some more, some nice things here to read. If you want to hear the voices of the mothers, even though you already know them, the Giving Voice to Mothers study is really important. This is a very deep qualitative study that shares what people of color have to say about their experiences. We should listen. And I'd love to hear from you. So if you all have questions, I would be thrilled. Have I got time? All right, let's do it. Who's got questions? Who's got comments? Whatever you want to say, I'm here. I want to hear it. And thank you very much. I think they're getting the mic. Yeah? Getting the mic? Okay. So, raise your hand, or stand up, or do what you need to do, or yell. Oh, I don't have any questions.